Kia ora. I'd like to acknowledge the traditional owners, the Wurundjeri people of the Kulin Nation and their elders past, present and emerging before I commence my talk today. So hip surveillance guidelines, what's changed? It always seems that we start reviewing these and it takes a lot longer for us to get from when we start to when we finish, but even though it's now 2021, we're calling them the 2020 version because really that's when we completed them. So just a quick reminder of what the Australian hip surveillance guidelines are for. It was really to provide an evidence base for recommendation for hip surveillance so that we can assess all children with CP. And I guess the guidelines are based on the principles of if we have early identification of hip displacement, it facilitates early intervention when there's lots of options available for various interventions. We want to optimise triage to orthopaedic services and to prevent progression to hip dislocation. We try to make it a standardised monitoring, and we want to have a balance of the risks versus the benefits. So one of the things that we look at each time we review when we're looking at the evidence is the risk of the radiation exposure, especially in low risk categories. And we really want to try and have a screening based on the risk factors that are most efficient and evidence-based. And really we're also, I guess part of it is we're trying to improve the health literacy for families and allow them to be involved in the decision-making process about hip management. So I guess quickly just the requirements, you really need to be closely aligned with a tertiary orthopaedic service with specialists, CP surgeons who are responsive to what's required, so we may need to fast track to surgery at times. We want to track children over time, and surveillance is very much about monitoring over time, not what you see on a single radiograph. We try to have good quality radiographs as part of surveillance, and really we try to have a feedback mechanism to families and other health professionals about the status of the child's hips, and that would be in some form of hip surveillance report. It's also important for us to evaluate the performance of the program, and we try and do all this in a systematic and coordinated approach. So the national guidelines, actually, I think we started in 2005. Somebody had a good idea over a glass of red wine or two, and we've gone on from there. So the original guidelines, which was the consensus statement in 2018, updated in 2014, and then again the latest version now. Just wanting to remind people that these are all endorsed by the Australasian Academy of Cerebral Palsy and Developmental Medicine, and part of that endorsement is that we do review them every 5 years, which is what's brought us to the 2020 guidelines now. So the process that we went through was, so we've had an Australian hip surveillance working group for some time, and one of the things that we were trying to do was have representatives of each state of Australia. Unfortunately, we still haven't actually represented the Northern Territory in our group there, but we also wanted to extend the group to include other than physios and orthopaedic surgeons. So we've had the inclusion of rehabilitation physicians as well as the physios and orthopaedic surgeons in the past. So I'd like to acknowledge the work of all the team members that are listed there for their help with the review of the guidelines. So Nuala, myself and Meredith, who unfortunately couldn't be with us today, have done the recent update of the systematic review, and we were fortunate enough to be able to, for the National Working Group, to meet in person in March last year at the, it seems a long time ago now, at the Australasian Academy conference. And though we all came from all states of Australia, and a few of us did go home with a cold, none of us went home with COVID, nor shared it with each other, so that was good. And then from that we developed the recommended changes via Zoom meetings and the like. So what our questions were with the systematic review was really we wanted to see was what evidence was there that hip surveillance programs are effective at preventing hip dislocation or progression of displacement, and what factors are associated with progression of hip displacement. And currently our publication is submitted and under review. So we used the same search strategies we'd used back in 2014. We used the methodology from the American Academy of Cerebral Palsy review to follow this. We were including any studies that included children from 0 to 18 years and looking at factors that would likely affect surveillance or the natural history in children with CP. So, for example, things like studies that use the outcome measures of MP, age, GMFCS, femoral geometry, range of motion, pelvic oblique scoliosis, and others. And because we'd done a complete review in 2014, we only searched from beyond that point. And then we just excluded studies that had limited numbers or weren't relevant to the CP population. This is just briefly the systematic review process, and we ended up with 43 studies included in the analysis, and we brought back the studies that we'd included in our previous review for the 2014 guidelines. And there were 5 studies that we were able to do quantitative synthesis and meta-analysis of some of their data. So one of the things that we did do in this review as well was we instituted using the grade recommendations for systematic review. And there in the left-hand corner, you can see the little symbols that are really about the certainty of the recommendation that we came for. So four little symbols is high, 3 moderate, 2 low, and 1 very low. And then if we look to the right, we could sort of see that hip surveillance programs are effective, and the evidence for that is high in 5 different studies. MP is still coming out as the best measure to detect hip displacement with a high certainty. Frequency should be considered if postural asymmetry and scoliosis present has some moderate evidence now. So we've changed some of the recommendations in the guidelines based on that. Guidelines should be stratified, still using the GMFCS, so that's great to see, and there's a high level of evidence for that. There's very little evidence based on using the Winters gauges Hicks for asymmetric kids with hip hemiplegia, but there is some evidence emerging that that's useful as well, and I will talk a little bit more about that as we go along. Age and pain, muscle tone and range of motion really still are poor predictors of risk of hip displacement. So I think that's a really strong message to remind ourselves that muscle tone and range of movement, there's very little evidence that is any use in predicting changes in migration or hip progression of hip displacement, but still do form part of our assessment for hip displacement. And we've also got some low evidence really about the need for surveillance to continue post-surgical intervention or after skeletal maturity. So that's some areas that we still need to look at from a research perspective. So overall, the effect was very high, and in these studies of large numbers of children, we found that there was 21 in 1,000 fewer hip dislocations based on children who'd been in a hip surveillance program. So the certainty of that is actually very high. So that's a big tick for hip surveillance. So just some of it now, just looking at the things that we've actually changed based on our systematic review. And frequency of radiographs is one thing that we always are concerned about. And our review really did support the reduction in frequency of radiographs for GMFCS level 1, as they have no significant hip displacement. So we've now taken out any recommendation for radiographs in this group of children for hip displacement. At GMFCS2 level, there's a decreased evidence, so we've reduced the timing of radiographs there as well. And at GMFCS level 3, 4 and 5, that really is supporting that annual surveillance is effective, but only really when you've got an orthopaedic service available and no significant scoliosis or postural asymmetries. And as I mentioned before, there's still some limited evidence on Winter's gauge and hips. So that really has brought us to really now our GMFCS level 4 and 5 guidelines are the same, and we're really still recommending 6 monthly, but if you've got stability of MP over 3 or more radiographs, you could easily reduce your surveillance to 12 monthly and 12 monthly for the GMFCS 3 level now. So when we looked at measuring pain and quality of life, so pain is associated with hip displacement, but it's a poor indicator of hip displacement, so in itself is not indicative. Pain is also associated with poorer hip morphology in the long run, and it's also associated with higher MP. So if someone's presenting with hip pain, it's something that you would want to follow up on. From some of the longitudinal studies that we found in our review, pains and severity and frequency was higher in individuals who hadn't had hip surveillance. So I guess the consequence of that is that they've had unmonitored and unmanaged progression of hip displacement, and health-related quality of life was associated with increase in hip migration. So for people who are saying that that might think that increased migration of hips may not impact on quality of life, it certainly does, and the literature is now showing that. So when we looked at what's the best measure to use for hip surveillance, MP is still the most widely used radiological index, and certainly is the measurement of choice. There are lots of other radiological measures that are mentioned in the literature. Neck shaft angle, head shaft angle, epiphyseal tilt from the measurements looking at the femur, and then if you're looking on the acetabular side of the hip, the acetabular index and Sharp's acetabular angle are all things that mentioned. But I think the thing to remember with these is that none of these measures are independent. They're all sort of interrelated, and often these are the things that will, plus other measures, and will be what an orthopaedic surgeon may look at and use to help decide what intervention or timing of intervention as well. So, we can keep our measurements for hip surveillance simple with just measuring MP. The CP-up risk score is a new measure as well, which is quite useful in GMFCS 3 to 5s as well. And there's a new measure which is looking at adjusting how you measure the MP based on taking into account for pelvic obliquity. And in our updated annotations, we talk a little bit about that. So if somebody had really quite severe pelvic obliquity, you may choose to use that measure. But once you've used the adjusted migration percentage, you should then continue to do so. And there's some guidance on that in the annotations as well. So just in summary, our updated guidelines now include evidence using the grade system to inform our recommendations. There's conclusive evidence regarding the effectiveness of hip surveillance and of the ongoing from that orthopaedic interventions to prevent hip dislocations. There's moderate level of evidence for low migration percentages correlating with pain and improving health-related quality of life. So I think that really is an indication for why hip surveillance is so important. And So just to quickly go through the changes that we've looked at as well. So GMFCS level 1, we're not recommending any radiological measures, but just review and checking from there. As a gait analyst physio, one thing I would try to remind people too is we're suggesting that you don't need hip radiographs for hip displacement in this group of children, but these children may require radiographs prior to gait correction surgery. So it's not necessarily that these children won't ever have a pelvic radiograph, but it will be for other reasons rather than routine hip surveillance. So the only time that, that's still important is at your time of review is that these children are checked that they are still actually at the GMFCS level 1. And once again, Winters and Gage's Hicks is a different group as well. So GMFCS level 2, once again, we've really, built on, the evidence is built on the fact that GMFCS level 2 have a low risk. So we've revised the guidelines to reduce the number and frequency of radiographs. So now we're recommending a radiograph at 2 and at 5, and then at 8 to 10, unless, any of the other things have changed. So the GMFCS levels changed, or their Winters and Gage Hicks classification has changed, or there's other risk factors that are identified that may be of concern. So that's reduced the amount of radiation exposure for GMFCS level 2. So at level 3, we've reduced the frequency of radiographs now to yearly, once still commencing at 2 years of age and continuing till skeletal maturity. And once again, at each review, you're assessing to ensure that the GMFCS level hasn't changed. At GMFCS level 4 and 5 now the guidelines are now exactly the same at level 4 and 5, but we've continued to present them separately, both on our poster and in the guidelines, because they may not stay the same in the future. So we didn't really want to confuse anyone with the way we've always set them out. So, but if you're reading them, they actually read exactly the same. And what we really have done is removed the where we used to say, you could, if everything was stable, you could stop for a little bit of surveillance between 7 years of age and 10 or 11 when they're close to puberty. But we're trying to maintain surveillance every 6 months, and if that hip displacement is stable, then it can be yearly. So that, we think, simplifies it a little bit and makes it a little bit less confusing. And once again, it just depends on checking that they still fit that classification. So there's some additional changes. We've tried to clarify the Winters, Gage and Hicks diagram a little bit. So we're really trying to make that emphasise that what we're really looking at in those kids is their transverse plane and coronal plane alignment. So if someone's has hemiplegia and they're really asymmetrical with pelvic retraction and elevation, these are the children that are more likely to be at risk of later, pre-puberty hip displacement. And so we're trying to just trying to make that a little bit easier. It's only ever affects a small number of children, but when somebody in that group has significant migration and hip displacement, it can take them from being functioning at a GMFCS level 1 to functioning at a GMFCS level 4. So, so we still think it's really important to single out this group, even though it may only be a small number of children. It's important just to, because it can be quite devastating. Just a few other changes. We're using the Australian spasticity scale now to replace the Ashworth, and we've really tried to update all the annotations with updated and additional references and clarification for some of them as well. So that's in there as well. So once again, I'd just like to thank our working group for all their hard work during this, particularly Nuala and Meredith, who worked on the systematic review. And our new look is purple, so I hope you like that, because it's difficult to choose a colour. And I've got my email address there, so if anyone would like a hard copy of the booklet or the poster, which is on the wall behind me, I'd happily send those out to you. And I'll just very briefly finish with a plug for the Australasian Academy and International Academy Conference in Melbourne, which we hope is going to be in person. So please all think about registering. Early bird registrations close on the 1st of November, and Melbourne's just dying to have a big event. So please come next year if you can. Thanks.